Welcome Dr. Naiem Nassiri to our urology grand rounds, who's going to be talking about hemodynamic, diagnostic, and therapeutic considerations in pelvic congestion syndrome. Dr. Nassiri received his undergraduate degree at the University of California, Irvine, and attended medical school at the Oregon Health and Science University. He completed his surgical internship at the University of California, Los Angeles, and was subsequently selected as one of the few individuals in the country into the newly established Integrated Vascular and Endovascular Surgery Residency Program, graduating in 2013 from New York Heart and Vascular Institute at the Lenox Hill Hospital. He was then recruited to Rutgers Robert Wood Johnson Medical School as the first integrated trained vascular surgeon in the state of New Jersey. There, in addition to practicing the entire gamut of vascular and endovascular operations, he was able to found, direct, and grow a number of collaborative, multidisciplinary programs, including the reputable Vascular Anomalies and Malformations program. Here at Yale, Dr. Nassiri focuses his practice on the endovascular repair of complex thoracic, abdominal, and thoracoabdominal aortic aneurysms, extracranial cerebrovascular pathologies, and the comprehensive management of vascular malformations. He's an active member of the Yale Aortic Institute, is the co-director of the Vascular Malformations program, and serves as Chief of Vascular and Endovascular Surgery at the VA Connecticut Healthcare System, and is the Site Director for Clinical Research for Vascular Surgery for the Heart and Vascular Center. Dr. Nassiri serves on the editorial board of the Journal of Vascular Surgery. So I'm looking forward to hearing your talk, Dr. Nassiri.
Thank you. Thank you, Dr. Kellner and the entire Yale Urology Department for allowing me this opportunity to speak with everybody today about this sort of confusing and ever elusive entity of pelvic congestion syndrome that spans several different specialties. These are my disclosures. So pelvic congestion syndrome is prevalent and perhaps underreported and underrecognized, and we'll go into the reasons why. It's a major cause of chronic pelvic pain, affecting up to about a quarter of the premenopausal population. And I'll stop there for a second, and you'll hear me talk a lot about female references and numbers and data that we have available. But please keep in mind that the gist of this talk is to give you a frame of reference that can affect both males and females. And just because some of the data in terms of public health is more available on the female side does not necessarily mean that the male population cannot be affected. So, you know, these sort of consistent vague symptoms of pelvic congestion syndrome were actually first reported as early as 19th century, but it wasn't until the mid-20th century that specific vascular etiology was associated with this phenomenon. And over the years, it has evolved into this sort of diagnosis of exclusion. And the reason for that is it has this sort of varying degrees of non-specific symptoms. There tends to be an inconsistent awareness in the medical community in a multidisciplinary range. And so it tends to be lower on the differential. In addition, the diagnostic workup for this disease entity really has not been standardized. And furthermore, even at high-level institutions, there is not always a presence of vascular expertise that feels comfortable managing this disease process. In addition, even if there's not a dedicated multidisciplinary efforts, and the lines of communication are not always there across different specialties that can take care of this process. So in my opinion, based on these reasons, I think this is an underdiagnosed, underreported, and undertreated entity. In terms of the demographics, we talked about the fact that 20 to 30% of premenopausal population is affected by this, and a variety of different reasons is etiological. And this includes acquired or congenital venous compression syndromes, which we'll talk about, inherited venous insufficiency, something as simple as varicose veins of the lower extremity can be a signal perhaps for pelvic congestion syndrome. And then, of course, hormone-mediated venodilations, peripartum intravascular volume fluctuations, and so on and so forth. And so, you know, signs and symptoms of pelvic congestion syndrome can be responsible for 10 to 15% of annual outpatient gynecological visits. So over the years, it really has evolved, and I think we finally have a very sound and definitive clinical definition of pelvic congestion syndrome. And this entails chronic, non-cyclical, dull pelvic abdominal pain that has been prevalent for, or has been around for 3 to 6 months at least. It is worse with dependence, Valsalva, menstrual cycle, and intercourse. And the assumption is that other more common causes such as neoplasms, cystitis, prostatitis, uterine fibroids, endometriosis have already been ruled out. Other signs and symptoms that are fairly classically associated with pelvic congestion syndrome include, as I mentioned earlier, varicose veins of the thigh, buttock, scrotal, and vulvar regions, and unexplained chronic hematuria. The urology community is often consulted on for doing a comprehensive workup. So it becomes an important thing to keep in the back of your mind as you're doing your hematuria workup. And the other thing that's sort of important is to please keep in mind recurrent left lower extremity venous thromboembolic events, venous insufficiency, asymmetrical left lower extremity swelling, varicosities, etc. And so please keep in mind the left lower extremity, and we'll go into why the left side should be a signal for potentially issues down the line pertaining to issues correlated with pelvic congestion syndrome. This is perhaps the most important slide of this entire talk. So if there's one thing that you're going to take away from this entire talk is this slide. And pelvic congestion syndrome, the pathophysiology is essentially venous hypertension. And venous hypertension is a pathophysiological process wherein the relatively low pressure system of the venous circulation has higher pressures within it, simply stated. And three major causes, and if you look at the vascular surgery literature, they'll talk about the first two. The third one is actually something that I have been advocating for our specialty to really emphasize, and it's an under-recognized entity in this realm. So the major causes of venous hypertension, number one is obstruction. And the most common thing that comes to mind is deep vein thrombosis. That tends to be an acquired entity, obviously. But there are also congenital or anatomic reasons for obstructive processes that can lead to venous hypertension. And these include venous entrapment syndromes and certain agenesis-related embryologic issues as well. We'll talk about these in detail. The second common cause of venous hypertension, or the second etiology of venous hypertension, which can oftentimes coexist with an obstructive process, is the process of reflux or valvular incompetence. Veins, as we know, are lined with valves that help propagate blood in an antegrade manner against gravity towards the right atrium. And so either as a result of congenital issues, acquired entities, inherited first, which can be inherited from autosomal dominant manner, can lead to incompetence of these veins. And as a result, blood tends to pool and cause elevated pressures. And the third, and I would say the most under-recognized entity, is the process of venous arterialization, most commonly as a result of congenital malformations, arteriovenous malformations or fistulae. But these venous arterialization pathophysiological processes can also occur as a result of iatrogenic causes or trauma, as you guys are all well aware of. Here's some anatomical refreshment. I don't need to tell this community about it. You guys are well versed in this, but perhaps for some of the trainees in the audience, remember that the gonadal vein more often than not tends to drain into the left renal vein, whereas the right side tends to drain directly into the inferior vena cava. And there are variants of this. The left renal vein has variants depending on its course relative to the aorta and the spine posteriorly. And there are certain areas that these compression syndromes that we talked about can lead to basically a traffic jam, if you will, of venous blood. And this can actually be quite profound. One location is right at the insertion point of the left renal vein into the IVC, the process of the so-called nutcracker phenomenon, which you guys are aware of. And also probably one of the most underdiagnosed and very common locations of venous entrapment is the process of May-Thurner phenomenon, whereby profound compression of the left common iliac vein at its insertion point into the IVC can cause profound regurgitation of venous blood into the pelvic circulation. And so as a result of these processes, we know that up to 15% of left gonadal veins are actually incompetent. just under 50% of congenitally competent ovarian veins tend to eventually reflux, a pretty astounding number. And 10 to 15%, there is a 10 to 15% prevalence of gonadal varices in the general population. And if you hone in on the symptomatic and infertile population, especially looking at the males, that number can be elevated to 35 and 60%. Let's talk a little bit more about these venous entrapment syndromes and other congenital anomalies, and I think you guys can catch the nutcracker reference over here. So again, a little bit of an anatomical refresher. May-Thurner syndrome, okay? This is one of those entities that tends to be often neglected, even in the vascular surgery community. And this entails the compression of the left common iliac vein, as you see over here, by the course of the right common iliac artery at the level of the aortic bifurcation. And what this does is it presses that vein or pancakes it against the spine. You can see on the venogram here on the far right, the imprint caused by the course of the right common iliac artery, causing essentially obstruction or occlusion of the left common iliac vein, which then tends to lead to dilatation, engorgement, i.e. venous hypertension of the iliac system, with pooling of the blood into the internal iliac vein, and as a means to try to find some escape, filling of the cross-pelvic collaterals into the contralateral side. So this can cause profound dilatation and elevations of venous pressure in the pelvic circulation. You can see on these MR images the extent of compression that can take place. This is the right common iliac artery. This is the left common iliac artery. This is the right common iliac vein. This is the left common iliac vein that is coursing anterior to the spine and trying to find its way into the IVC, but it's being completely, essentially occluded almost by that right common iliac artery. You can look on the sagittal cuts here on the bottom right here, that degree of compression, which is fairly profound. Moving along, the nutcracker syndrome or left renal vein entrapment syndrome. We know that the left renal vein courses most commonly between the superior mesenteric artery and the aorta prior to its insertion point into the IVC. So in situations where, looking at this cartoon, for example, you have a fairly acute angle between the SMA and the aorta. Oftentimes, acute angles of about 20% are reported, especially in thin individuals who tend to not have too much visceral adipose tissue, and i.e. there's not that much cushion, if you will, separating these two entities. You can have a very profound compression and narrowing of that left renal vein. And so again, the process of venous hypertension comes into picture. And so as a result, you can have dilatation and engorgement of that left renal vein. If there are robust collaterals through the lumbar, adrenal, and the gonadal veins, these tend to oftentimes be culprit vessels for dilatation. You can appreciate how that can lead to engorgement and dilation of this vein, and the valvular competence of that vein can become quite compromised. And then oftentimes this gonadal vein will then find its escape circulation through the left internal iliac vein, and it tries to escape through the common iliac vein. You could imagine that if someone has concomitant May-Thurner syndrome, they essentially have gelled out their ovarian renal vein escape circulation, and that venous blood really has nowhere to go. In addition, that venous hypertension, if profound enough, can then lead to a significant amount of hematuria that may otherwise have no other etiology behind it. Take a look at this duplex ultrasound view, and you can see here's the aorta in the bottom. This is the takeoff of the superior mesenteric artery, and you can see essentially completely flattened and annihilated lumen of the left renal vein. This is a young lady, a patient of mine from years ago, who was given all types of psychiatric diagnoses of anxiety and schizophrenia because no one could really figure out why she was having such profound abdominal flank pain. And with just a simple CAT scan, we were able to find and identify a nearly occluded left renal vein with dilatation and engorgement. And you can see that her entire left kidney was being drained through this very tortuous, dilated, elongated ovarian vein, which was dumping all this blood into her pelvic circulation. We talked about arteriovenous malformations briefly, and what these are is essentially an abnormal connection between feeding arteries and draining veins anywhere upstream of capillary level. So that high resistance vascular bed of the capillaries has been removed. So in essence, you're dealing with a low pressure sump that continues to recruit blood, arterial blood, into its nidus. That nidus can either be this conglomerate network of poorly differentiated blood vessels that have neither an arterial nor a venous designation, or it can manifest itself more as a direct fistulous connection, which we oftentimes see, for example, in cases of a congenital renal arteriovenous fistulas. Here's a case of Rondo Osler-Weber syndrome, which is a diagnosis that's very commonly associated with visceral and pelvic arteriovenous malformations. This is a lady who is having chronic pelvic and abdominal pain, and with one look into her tongue, that demonstrates the pathognomonic telangiectatic lesions in the mucosa, as well as in the acral aspects of the digits, has features that suggest the syndrome. And she was found, lo and behold, to have a left ovarian artery to ovarian vein arteriovenous malformation with profound aneurysmal degeneration of the draining veins, which was the responsible process for her pain and discomfort. We published on one of the largest series looking at congenital renal arteriovenous fistulae, and you can imagine that these abnormal connections between the renal arteries and the draining veins can mimic diagnoses such as renal artery aneurysms, which tend to be more common, but you can appreciate that the profound dilatation and aneurysmal degeneration of the draining veins. You can see how undilated and engorged these renal veins are. And that's an important take-home message. Oftentimes, folks think that arteriovenous malformations tend to manifest themselves in Steele phenomenon or end organ malperfusion as a result of the shunt that takes arterial blood away from the organ into the vein. But the earliest and perhaps the most profound manifestation of arteriovenous malformations and fistulae are actually venous hypertension as a result of venous arterialization. So let's talk about some of the diagnostic imaging modalities that can be done to help delineate this. And first and foremost is the concept of duplex ultrasound. I love duplex, and the reason why I like duplex is it's like solving a puzzle, because it has several different modalities that can provide some tremendous amount of information that can be quite helpful. First and foremost, on the top, you can see what we call B-mode imaging, which is that grayscale Doppler that actually gives you an image depending on the resolution and the capability of the ultrasound equipment, what entity you're dealing with. This is a scenario where you're starting to see a very profound network of dilated periuterine veins, which are suggestive of quite a bit of congestion in that area. But then in addition to that, when you want to characterize this further and come up perhaps with a diagnosis, you can then superimpose color flow Doppler. And that color flow Doppler can give you a tremendous amount of information about the orientation of blood flow, turbulence of flow, so on and so forth. And lastly, and perhaps most importantly, is that bottom figure is what we call spectral waveform analysis, where it gives you these sort of characteristic features of what that blood flow is looking like. Are you dealing with a scenario where it's a high flow, low resistance arteriovenous fistula situation? Are you dealing with a venous pattern of blood flow? If you are dealing with a venous pattern of blood flow, are you seeing a scenario where there's an obstructive process? Are there respiratory variations that are characteristic of normal venous blood flow? Are those are those respiratory variations not present? These are all things that the duplex ultrasound, if done properly, can provide a tremendous amount of information for the diagnostician. Duplex ultrasound is dynamic. It's a live study. It is non-invasive. As I mentioned, it can give you multimodal information, but positioning is key. Placing the patient in reverse Trendelenburg position, or sometimes it can be done with the astute technician in an upright manner. Mimicking Valsalva is key in order to bring about some of these features that may be picked up on imaging. The limitations are, of course, that it's technician dependent, it is body habitus dependent, but nevertheless, it's an excellent initial screen. And so duplex ultrasound is a very good initial study for these, and we tend to start off with that process. Moving on, CT and MR venography, and I want to emphasize the venography portion of this. Sometimes you have orders for CAT scan with contrast or MR with contrast. It has to be taken one step further, and a formal angiographic component has to be superimposed on this. And these provide you with excellent resolution. They are, however, static images. You are dealing with radiation and contrast considerations. And perhaps the most important thing to keep in mind is that please don't forget the patients are supine in these positions. So someone may have, so in order to go directly to CAT scan and MR, I think it's a little bit of a misstep, because if the features are not quite profound, you place the patient in a supine position that alleviates their symptoms, and you may not be able to detect the underlying pathology with CAT scan or MR alone, despite the fact that you have such excellent imaging resolution. Laparoscopy or other surgical explorative techniques, they can help detect other etiologies, and is perhaps a very valuable tool as part of the workup, but it is invasive. Don't forget, please, that you're dealing with gas insufflation, which can actually compress the very veins you're trying to interrogate. And oftentimes the patients are in Trendelenburg position. And so again, that venous dilatation or engorgement may be falsely masked. Catheter-directed venography is essentially the gold standard, and it does away with a lot of the limitations that I just talked about. It actually has been recommended as the gold standard treatment for investigation of pelvic congestion syndrome based on multi-societal guidelines. It is a dynamic maneuver. It can actually be done with positional manipulations that can help mimic the actual factors that can bring about the symptomatology, and you can perform concomitant therapy. Obviously, you're dealing with contrast exposure, but I think that's a small risk when you're looking at the grand scheme of things. Here's a scenario where a patient was having chronic pain and discomfort. Neither CAT scan nor MR nor ultrasound was providing a tremendous amount of information. A simple venography done appropriately with deep inspiration, mimicking Valsalva, demonstrated a profound amount of reflux of iliac venous blood into the internal iliac venous system, filling the cross-pelvic collaterals, suggestive of an upstream compression process. So with that in mind, so let's talk about treatment, and then we have some cases that we can go over. So perhaps one of the most highly championed surgical procedures dealing with these venous entrapment syndromes is transposition of the left renal vein. This was a technique that was championed by one of our renowned colleagues, Peter Glowicki from the Mayo Clinic. I think Tom Bauer and some of the other folks have published extensively on this. They have perhaps the largest experience with this, whereby they essentially sag off that left renal vein off of that acute angle between the superior mesenteric artery and the posterior lying aorta, and with or without patch angioplasty, they transpose that onto the vena cava. This can also, as I mentioned, be done in a concomitant manner with venous patch angioplasty to help mitigate some of the intimal hyperplasia that can take place, that can narrow the surgically recreated venous conduit. And folks have also commented on the invasive but nevertheless performed process of gonadal vein transposition, ligation and transposition onto the IVC. So keep that in mind. It is something that's talked about, and I think in a very loose manner has been sort of heralded as sort of the go-to maneuver for treatment of some of these venous entrapment syndromes, mostly for the nutcracker process. But the Mayo Clinic actually looked at their own experience with these transpositions. They looked at 37 patients over a 20-year period, 30 of whom were female, 7 were male. The vast majority had been presenting with flank pain, abdominal discomfort. Hematuria was actually present in 70% of these patients. And they had pretty decent follow-up of a mean of 36.8 months, plus or minus 52 months, ranging up to 216 months. And they had performed a left renal vein transposition in 36 of these patients. 11 of these, so in essence, 30% required reintervention, which is not a small number. And if you look a little bit more closely, 8% of these had to be done within 30 days. And the bailout for the surgical maneuver was actually stent placement. 22% or 8 of these were done beyond 30 days, And the vast majority, again, were bailed out with stents. So in essence, 1 of 3 patients undergoing this major abdominal surgery will require reintervention, most frequently left renal vein stenting. The group out of Pittsburgh took another look at this. They looked at their renal vein stenting process. This one was done relatively recently and was done sort of in the heyday where there was some suggestion that stenting may not be as effective or has poor patency outcomes. There was some thoughts that there was a large experience reported from China where there was a suggestion of perhaps migration of these stents. And please keep in mind, at the time, we did not have dedicated venous stents for these entities. But nevertheless, they looked at their experience, 18 patients, 17 were female, over an 8-year period. And interestingly enough, they had 5 patients who had been previously reimplanted surgically. So this kind of correlates with the Mayo Clinic experience that about 30% of these patients who undergo surgical transposition of the renal vein require reintervention. Their follow-up was also relatively decent, 41 months plus or minus 26. And they had only a reintervention rate in only 3 patients at a mean follow-up of 24 months. So at 2 years, their primary and primary assisted, and primary assisted means that another endovascular intervention was needed to keep the stent open, was actually 85% and 100% respectively, which is respectable. And there was no cases of stent migration. So endovascular therapy, to summarize, it can be performed at the time of diagnosis, can evaluate various culprit vascular beds. It can treat the reflux as well as an underlying etiology. You can perform multiple therapeutic modalities. It's not just the stenting, but other things that, as you'll see in a little bit, we'll talk about, can be performed in the same setting. You can perform embolization of incompetent veins and arteriovenous malformations, as well as performing a venoplasty and stent placement of compressed venous outflow tracts. And lastly, and perhaps the latest tool in our armamentarium, is that endovascular therapy can help facilitate intravascular ultrasound, which gives you irrefutable evidence of exactly what's happening with these veins, either from an incompetence standpoint or from a compression standpoint. So this is that lady with Rondo Osler-Weber syndrome that we had demonstrated earlier. She had as you can see in the picture, in the second picture, selective catheterization of her ovarian artery demonstrates a very large, dilated, tortuous ovarian artery that is feeding this arteriovenous shunt with aneurysmal degeneration of a draining vein, which is then subsequent to that feeding this ovarian venous system, causing venous hypertension, dilatation, and incompetence of that left ovarian vein. So venous arterialization leading to venous incompetence. Looking at that artery, we saw that there was a very large tortuous course that prevented us from being able to access the arteriovenous malformation from an arterial side. So we decided to go the other way, take the back alleyway. So we selected the left renal vein, went into the left ovarian vein, and developed a coaxial catheter-based system, and were able to interrogate and catheterize the culprit site where this fistula was taking place. Once there, we deposited this scaffold of coils. These are platinum-based coils that served as a scaffold. And onto the scaffold, we deposited this material called onyx, which is in essence ethylene vinyl alcohol copolymer. It's mixed with dimethyl sulfoxide. In essence, it's a lava-like compound that can be injected and basically fills the gaps like cement. And you can see that on the completion angiogram, we had completely done away with that arteriovenous shunt, and which led to very prompt symptom resolution. Here's that 20-year-old girl whose image I had shown before. I had brought her in, I performed a diagnostic aortogram. And on initial early phase arteriographic runs, you can appreciate no demonstrable abnormality. There's no arteriovenous shunting. There's no major alarming features that are jumping out at you. But on delayed arterial venous or venous phase runs on the arteriogram, what we start to notice is that the left parenchyma of the kidney is draining much more slowly than the right side. So the washout of the left kidney is much slower. So that suggested to us that perhaps there's a hemodynamic, there's something going on in the draining system of the left renal vein that's concerning. So we go through the inferior vena cava and put our catheter directly into the left renal vein. And lo and behold, we see this profound bird beaking. that is suggestive of a near occlusive region. We cross this lesion and put a diagnostic catheter in the left renal vein and do a venogram, and lo and behold, there's actually no flow whatsoever into the left renal vein. Everything is being drained through this left ovarian vein, which is taking just a remarkable tortuous course and draining itself into the pelvic circulation. And this is, in essence, all this venous or renal venous blood that's being dumped into this pelvic circulation. So we balloon venoplasty the site of compression. We were hesitant to put a stent in this young patient because she did not have a profound amount of hematuria. And by depositing some coils, we were able to plug the drainage pattern into that left ovarian vein. On completion venogram, you can now finally see brisk outflow into the left renal vein and no further filling of that left ovarian vein, which completely eliminates her symptoms over a course of several months. Coil embolization of refluxing veins is a common procedure that's performed. There is no standardized treatment algorithm for a lot of these entities. I've come up with sort of my own way of going about doing these. If they don't have hematuria, and that hematuria has to be clinically significant, for example, they're anemic or they're requiring regular blood transfusions, what I tend to do is I tend to focus on the reflux. In other words, plugging the refluxing vein, the culprit vein that's dumping all this kidney blood into the pelvic circulation. By focusing on coil embolizing that, I tend to do away with a lot of the symptoms that the patient experiences. If they're not having hematuria, I'm hesitant to put a stent in them. However, if gross hematuria exists on a daily basis, but simply eliminating the refluxing veins, which are draining into the pelvic circulation, is not going to be sufficient enough. You have to augment the venous outflow tract. So coil embolization is a process that can be done in many of these patients that can help do away with a lot of the pelvic congestion syndrome pain and discomfort that they may be experiencing. This is not that far removed from ablation of varicose veins. It's the same process. Refluxing veins with venous hypertension undergo ablation so as to eliminate blood flow into these culprit veins and redirect that blood flow elsewhere so as to take the venous hypertension pressure off these affected veins. Here's the case of the May-Thurner syndrome that we talked about earlier. You can see the imprint on the left common iliac vein with a simple placement of stent after performing intravascular ultrasound. You can see no longer are you seeing venous compression. You're no longer seeing venous hypertension, pooling of the blood into the internal iliac vein, and a very brisk outflow of left iliac venous blood into the inferior vena cava. We talked a little bit about intravascular ultrasound. I have a case here. This is a young man in his late teens who had sickle cell trait, was having a profound amount of hematuria on a daily basis, had gone through the gamut of the entire workup. No one could really figure out what the issue was. And finally, his pediatric urologist was astute enough to refer the patient. We had performed both MR and CAT scans on him and confirmed that he had nutcracker syndrome. We confirmed the hemodynamic significance of the nutcracker syndrome by performing this intravascular ultrasound. Here's the lumen of here's the intravascular ultrasound catheter, this little white circle. Here's the compression of the left renal vein. And actually you can compare the compression point and compare this to the more dilated portion of the left renal vein. And any surface area compression beyond 50% we deem as hemodynamically significant. We brought the patient in, and through the transfemoral route, we're able to place a stent into the left renal vein. And you can now appreciate augmentation of the left renal vein lumen caliber. Here's the green little circle before, and this very large augmentation of the left renal vein, which completely treated his hematuria. He did away with having to get daily or regular blood transfusions, and his failure to thrive was resolved in a major way. This is another young lady whom I treated right here at St. Raphael's campus. Similar scenario, late teens, daily hematuria, failure to thrive, profound nutcracker phenomenon. You can see barely any filling of the vena cava as a result of the drainage from the left renal vein. And through a transjugular route, we were able to place this dedicated venous stent, which we now have available, and augmented her renal parenchymal drainage. you can see on beam mode imaging the caliber of the stent and the colorful Doppler that shows augmentation of flow. Other therapeutic options that have been talked about, I think medical and hormonal analogs and analgesia, you know, they tend to have side effects. They have a very limited dose-dependent clinical response. Obviously, there's recurrence upon cessation, and they can perhaps be good co-treatment alongside endovascular measures. And I think it's an interesting area to study. And also, you know, some of the surgical maneuvers we talked about, by and large, societal guidelines advise against some of these major surgical interventions for the sake of treating pelvic congestion syndrome because of the risk factor profile. But all in all, I would say these other therapeutic options, they're good co-treatments, but they have a very limited focus, both anatomically and clinically, because they don't really address the primary etiology of venous hypertension. And they are simply masking the presenting symptoms rather than treating the underlying vascular process that is very real and is there. Endovascular outcomes, they have been reported since the early 90s. The technical success rate tends to be consistently above 90%. The clinical success rate is just as good. They have a very good portfolio in terms of pain elimination, reduction, and improvement quality of life. While we don't have as good of a follow-up as we have with some of the more surgical procedures, but they have sustained resolution of pain and discomfort at a mean follow-up of 48 months. Then the recurrence rates tend to be negligible if done in a proper manner, keeping in mind the pathophysiology, the underlying pathophysiology, and addressing that in the appropriate manner. Complication rates are fairly low, less than 5%. One of the most common things that is encountered is this post-embolization syndrome, which is in essence a pelvic or abdominal thrombophlebitis, which is actually a good sign. It is associated with pain and discomfort, some low-grade temperatures, and almost 100% of the time it tends to be resolved by itself. Non-target embolization, these are some of the technical issues that, if done in an experienced hand, is essentially non-existent. And there has been no demonstrable long-term effects on hormone levels, menstrual cycle, and fertility. So in summary, I hope I was able to demonstrate that the pelvic congestion syndrome is a common clinical entity. I hope you've appreciated that it's not recognized consistently because of these generalized and non-specific symptoms, and that it remains a diagnosis of exclusion. So I hope that we can actually keep it in the back of everybody's mind on the under differential list. The primary mechanism is venous hypertension due to obstruction and or reflux and or venous arterialization. And properly performed diagnostic imaging is a key maneuver, keeping in mind some of the positional components that we talked about. Catheter-directed evaluation with concomitant therapy is really the gold standard for not only diagnosis, but obviously treatment. And some of the areas for improvement, in my opinion, are standardizing the diagnostic workup, improving communications between various service lines, coming up perhaps with what I would suggest a pelvic vascular disease program where multiple specialties can come in and weigh in on these. We rely oftentimes on the expertise of the referring specialist to have ruled out other more common causes before the patient is referred to us. So that's a very important maneuver. And also timely therapy can do a lot for the patient from a psychiatric and psychological issue as well. And then routine follow-up with the treating physician is also very key. And I would emphasize routine follow-up in a multidisciplinary manner. I do think that it's a very real entity with some very real anatomical vascular components, which requires heightened awareness and a true collaborative approach if we're going to tackle this problem. And with that, I'll open up to questions, and I thank you very much for your time. I'll also stop sharing my screen.
Thanks so much for a very interesting talk. I have a couple questions. So one is the data you presented about endovascular approaches, so stenting, when you said since the 90s, so those were obviously arterial stents used off-label. And then we brought into our system, I think it was last year, the Venovo stent. But now we have two additional stents that have been requested for addition, the Abre and the Vici. I think it's Medtronic and Boston Scientific. And one of the challenges in trying to decide whether these stents should come into the system or not is the total lack of good data. right? And the Venovo stent was, everyone was excited because, boy, it's going to be great for pelvic compression. And, you know, we're using these arterial stents off label. But now, as these two new stents have been requested, they're being requested because the Venovo stent is problematic, right? So if the endovascular data was so favorable with the arterial stents, why did we need to bring in the Venovo stent anyway? And if the endovascular repairs are so good, what's the problem with the Venovo stent that we need two additional ones?
Good. No, very, very astute questions, and I'm very happy to hear you talk about some of these stents. So to address your first question, the arterial stents being used off-label, obviously it's not the most ideal scenario. And we deal with this all the time in endovascular and vascular surgery, you know, using device, for example, even the arterial stents themselves. If you take a look back at sort of the evolution of arterial, and by stents, I mean lower extremity or any extremity related stent. These were actually biliary stents that were evolved over the years. There were bronchial stents that were used. For example, one of the covered stents that we were using, the atrium ICAS, initially was indicated for bronchial stenting. And it really wasn't until years later that they were able to finally get FDA approval for placement of these stents. And then even then, some of these indications are for infrainguinal or femoral popliteal level stenting. So if you were to use these stents in the iliac arterial segment, for example, it's technically off-label. And so this is not an unusual thing. I know the term off-label sounds bad, but in vascular surgery, we do this all the time. So to address your first very good question is that if the arterial stents are so good, why are we? The venous caliber tends to be much larger, right? So when we're dealing with venous caliber stents, up until these sort of onslaught of dedicated venous stents that came out, the only thing that we had available to us was the Boston Scientific wall stent, which was sort of this generic stent that really had an indication for vascular stenting, right? It was this sort of rigid kind of platform, you know, had a closed cell design, and it really didn't have features that made it amenable to dedicated venous anatomy. The calibers, if you looked outside the wall stent from the arterial side, just were not large enough to help accommodate renal vein stents or iliac venous stents. So there was definitely a clinical need for dedicated venous technology or venous stent technology that could accommodate some of these anatomical restrictions. As far as the issues with the Venovo,
one question was asked, but how come that's not reflected then in what you referred to as like negligible recurrence? Is it just that there were some people that you didn't have a stent, there were people going untreated, or what was do you know what I mean? So it's either because the data you said are very favorable, even when you didn't have a dedicated venous stent. I'm just wondering absolutely what the problem was that was getting fixed.
Despite the fact that it was being used off-label, we still had very good. A lot of that data that you saw was being done with wall stents, which up until this recent point where we had this dedicated onslaught of dedicated venous technology was really the go-to stent for a lot of these venous indications. And so you're right that despite the fact that there was no dedicated venous technology, we still had pretty good data demonstrating favorable outcomes with essentially off-label, if you will, venous technology. And so there was a lot of enthusiasm for, as you mentioned appropriately, for a lot of these dedicated venous technologies that sort of came about. The Venovo was, and we see this again in the endovascular realm. For example, you know, Medtronic just had a major recall for some suture interrogation process for their thoracic stent graft for the aorta. And so they tend to do a root cause analysis, and they find one specific site where the stents were not placed properly. So to have a device recall is not necessarily reflective of the performance of the stent. We see this a lot, kind of like automobile manufacturers. You know, the air conditioning for the car may be problematic, so they recall it and they address the problem. I really like the Venovo stent. I actually think we have a couple of other ones. I think the competitors tend to kind of jump on it as soon as one stent has a problem. Other ones really want to come in and just get some market share. But I think it's a matter of, I think we're definitely headed in the right direction. I think using a dedicated Venovo stent, I actually have continued to use the Venovo stent. It was a problem with recapturing of the stent when you're dealing with a larger profile or larger diameter stents. There are actually technical ways where you can circumvent that. So I actually talked to BARD about this, and they've actually done away with the problem. So it's not an uncommon entity where the stents have some glitch in terms of their deployment, depending on the size and diameter. So that should not necessarily preclude you from using the device if you have good insight into what the cause was, and the company has addressed it properly. So I hope that helps address the concerns that you had. It's not necessarily a reflection on the performance of the stent pertaining to the anatomical issue of the patient and what the long-term patency hopefully will be with these.
Naiem, that's excellent talk. I just have a question for you. As urologists, one of the things that we often will see with patients with chronic scrotal pain, and at times we'll see that they have a left-sided varicocele. But then sometimes they talk about pain that goes down their leg, and so we started thinking about, well, maybe this is some sort of referred pain, like a radiculopathy, herniated disc or something like that. So can you talk a little bit more about that left thigh pain that's more common? Because someone has a varicocele and we fix the varicocele, but the pain also was in their leg. Is it something that, if it is a venous problem, it should be more of a proximal treatment versus just doing what we usually do would be like a subinguinal approach to surgically treat the varicocele?
It's a very good question that is a direct reflection of the anatomy. And please keep in mind, the venous circulation is so intertwined, right? For example, we know that, and you guys know that, perhaps one of the major reasons why you tend to see varicoceles a little bit more commonly on that left side is the fact that it drains into that left renal vein, and there can be all sorts of issues with that left renal vein, whether it's it's bifurcating, or it's a retroaortic left renal vein, or perhaps there's a compression there that has gone unnoticed for a very long time. And I use this analogy with patients is that there's a traffic jam in the freeway. And so, like, unless you address the traffic jam, you can reroute the traffic as much as you want. You're still going to have congestion. So the main problem has to be addressed. Another example I can give you that can help answer your question is that oftentimes I get patients with varicose veins that come and see me. They want a second and third opinion. We're saying, well, doc, I had my varicose veins ablated in my left leg years ago, and I did well for a few years, but now it's sort of come back, and I don't understand because everything was treated. And you get an MR of the pelvis, and lo and behold, they have May-Thurner syndrome, and that they have the left renal vein compressed. And so, unless you treat the problem from its root, and so you have to address that congestion first before you can do anything else to address the remaining manifestations of that venous hypertension. I think part of the reason why you're seeing some of these things is that the drainage pattern for the pampiniform plexus can actually it can go into the circumflex iliac vein. There's actually can drain into the saphenous vein. So there can be that sort of reflux, right? It's the same process of venous hypertension. The vein is just trying to find some way out, right? So it'll go and drain perhaps into the saphenous vein. The other thing that we know is that venous insufficiency, right? Oftentimes you'll ask the patient, say, oh, so do you have any history of varicose veins? And say, oh, my mom had it and my grandma had it. We haven't delineated the exact, the mutated pathway. I don't think there's a genetic mutation that's been attributed to this. I think in the era of DNA sequencing, we may very soon have an answer to that. But we know that there is a component or subset of patients with venous insufficiency who are inheriting this in an autosomal dominant manner. That's been documented. So the answer to your question is essence venous hypertension, and that venous hypertension tends to want to find some escape, some route of draining itself, be it through the saphenous venous system that you may encounter when they're talking about this thigh pain. So it's not so much radiculopathy that I would say is perhaps a reflection of the venous hypertension, or it may wind itself in the pelvic circulation. I think in males it tends to drain a little bit more, especially when you're dealing with varicoceles. It tends to have an easier track of escape into the saphenous venous circulation of the upper thigh and the groin region, rather than going directly into the pelvic circulation, although that can happen as well, especially if you're dealing with a scenario where there is a left renal vein compression that has not been addressed. And I think that's the whole point of this talk, is that if you get a scenario like that, let's not focus on just where the problem is. Let's take a step back and look at the broad picture, and perhaps this individual may have a left renal vein compression that has not been looked at. And have we taken the necessary steps to make sure that they don't have May-Thurner syndrome? Have we taken the necessary steps to make sure that the left renal vein is not compressed? And if those things are, then I think a multidisciplinary discussion about how to go about treating it and what your approach is and what I would suggest, and sort of that kind of bringing the minds together and just opening that dialogue in and of itself, I think does tremendous things for the patient.
Thank you for that talk. I have a question for you, some background, a question, and potential research idea. We see these patients who have gross hematuria. The standard workup is including a CT urogram. I have to admit, I really haven't thought about this entity that you've very nicely described. When they do a CT urogram, they do an abdomen pelvis without contrast, and they give contrast, do a study at about 90 seconds to get a nephrographic phase, and then somewhere around 8 minutes do an excretory phase, so it lights up the ureter and other parts of the collecting system. And I appreciate what you said about if they're laying on the table and not standing and dependent, then you may not appreciate things. But I wonder if there are findings that you've noticed that we can be aware of on a CT urogram that are subtle. And if that hasn't been looked at and the patients that you've accumulated, that might be an idea to look at for some subtle findings, because that's the study that most patients get when they have gross hematuria. Maybe in retrospect, looking back at it in the 3 phases, you can see some subtle findings. I don't know.
Yeah, that's a very good point. And what I would say is that let's sit together and let's look at some CT urograms together, and let's see how much information we can get based on these. While it's a contrast enhanced study, it is not enhanced specifically for the purposes of venous delineation. So what would be very good, and I think could be promoted in the urological realm, would be if, as part of your workup, right, if adequate enough, if this CT urogram is adequate enough for the areas that we talked about, i.e. the caliber of the gonadal vein, or the ovarian vein, or the testicular vein, or whatever you're looking at, the compression of the left renal vein. I haven't looked at enough CT urograms to be able to tell you whether I can tell you adequately whether that left renal vein is compressed enough, or I can comment on the engorgement, if you will, if present, of the gonadal vein, or if the pelvic component of this is adequate enough. Can I see the compression of the common iliac vein adequately enough? Can I comment on the caliber and the dilatation of the internal iliac vein? Those are all things that I would love to sit down with you and take a look at, maybe look at 5, 10 of them and say, hey, we're seeing these things, right? And then perhaps you can say, like, historically, you've looked at this many CT urograms, and of these CT urograms that were done as part of the diagnostic workup for hematuria, let's say, and I'm just throwing numbers out there, 25% of them were found to have significant compression, and we can come up with criteria for what we would call significant on CAT scan. This many of them had a significant compression, and would it have been worthwhile to have addressed that? How many of these had recurrence, and so on and so forth? So I agree with you, it would be a wonderful, and that's the whole purpose of this talk, is to really open up this dialogue and think about how we can do this better. I think there was a question, Dan. I don't know if you want to.
Yeah, so we have a question in the chat, and it just asks, do patients receiving a venous stent need DAPT or anticoagulation following stent placement?
Very good question. If it's done, so the May-Thurner syndrome, one situation that comes up a lot, you'll have a young lady who's having issues with menses and a lot of pain and discomfort, and they'll see their gynecologist, and they'll be started on hormone replacement therapy, right? Which can oftentimes, I mean, I know there are options out there that are not as problematic, but traditionally speaking, it can cause a hypercoagulable state. And they'll wind up with left-sided DVT, right? And that's the other thing that can happen, is that it's not necessarily a lifestyle issue. They can actually wind up with really devastating deep vein thrombosis extending from the cava all the way down, and can actually wind up with pulmonary embolism and so on and so forth. So they'll present with this acute DVT. You'll treat it. You'll eliminate the clot if you can, and then you do your intravascular ultrasound, and lo and behold, the main culprit, right, was, it's that Berghaus triad of, stasis and hypercoagulability and injury. That is unmasked. That May-Thurner phenomenon is unmasked. So those patients are generally speaking, that would be perhaps be a scenario that's a provoked DVT. So they would be on anticoagulation for some time. And if you do treat their May-Thurner syndrome, you generally put them on Plavix for at least 3 months. And that just being on Plavix for 3 months is a key maneuver. If they don't have a concomitant venous thromboembolic event, then I put them on dual antiplatelet therapy for at least 3 months. And then afterwards, I keep them on lifelong aspirin indefinitely. And I really encourage them to really stay on that. It's a very good question.
One follow-up question about the stents. So if you use a relatively long venous stent, you had a diagram showing, pretty extensive valves. The stents themselves are not valved. So what's the thought about, if valves are an important part of the venous system and you put in a long venous stent, is that not a problem?
So we're not placing these stents in veins that have valves. So you would not put a stent in the ovarian vein or the gonadal vein for in a situation where the vein is actually positioned in a very deep. So the veins that have to deal with gravity a lot, they tend to have a higher prevalence of valves within them. So for example, lower extremity veins, right, especially as you start to go more distally in the lower extremity, they tend to have a higher number of valves than if you were to look at the upper extremity. And the reason for that is your legs are much more dependent, and we've sort of evolved to have more valves in our lower extremity venous circulation than our upper extremity circulation. The left renal vein doesn't have valves because it's not working against gravity. So putting a stent there augments that. You're not putting a stent in the ovarian vein that has valves. Those veins are actually just coil embolized, and we shut those veins down and we redirect blood elsewhere so as to not have that pulling and discomfort into the pelvis.
Okay, are there any other questions? It's 8:28, and so I know people have to start surgery soon. All right, well, I want to thank Dr. Nassiri. It was an excellent talk, very well attended. I think we had 106 people at one point. That might be a record for our urology attendance. So it was great having you, and we appreciate it.
Thank you. Thank you for the opportunity.
Okay, thank you. Have a good weekend, everybody.